Some days it seems short, some days it seems long, but 5 months ago. When Trees Harms recently asked if I'd be willing to participate in today's forum, I didn't hesitate. 1 in 8 women will be diagnosed with breast cancer. I can speak to that firsthand, that timing is of the essence. My willingness to share my story and the importance of early access to testing directly led to my cousin being diagnosed with breast cancer just 4 months later. Jenny is 22 years my junior and has 3 little girls under the age of 8. She's a busy mom and put off scheduling her first mammogram. After my diagnosis, it prompted her to go get herself tested. And while I'm happy to announce that I'm currently cancer-free, my cousin is meeting with her doctors as we speak today, November 1st, to get her complete diagnosis and start to go into what the treatment plans are for her. So today will be an important conversation about removing barriers for breast cancer patients, resulting in increased survival rates while simultaneously lowering treatment costs. So the agenda for today, we're going to have a brief overview of breast cancer in Iowa. We're fortunate to hear from an impressive panel of women, including Mrs. Barbara Grassley, Dr. Rachel Preisser, and representatives from the Komen Foundation. Like myself, a couple of these women are breast cancer survivors as well. They'll speak to the barriers facing Iowans seeking breast cancer screening and treatment, as well as inform us on pending legislative solutions. As far as a little bit of house cleaning here, if you do have questions today, please feel free to post them in the chat in real time. We will have a designated Q&A session at the end as well. So cancer in Iowa. A few stats related to cancer in Iowa. Breast cancer is the second most common type of breast cancer or of cancer in Iowa. It's second only to skin cancer. About 2,700 Iowa women will be diagnosed in 2023. An estimated 380 women will lose their battle with breast cancer this year alone. There are ways that more deaths can be prevented. Early diagnosis is key. However, 1 in 4 women will not follow up with a recommended diagnostic screening because insurance will not cover it. So I personally can speak to the importance of early diagnosis. My breast cancer was initially detected during a routine standard mammogram. However, the first mammogram rarely, it almost always, I get called back and have to do a second mammogram for about 50% of the time I've had to do that. So additional diagnostic testing was ordered in my case due to abnormal but inconclusive imaging. That's caused by dense breast tissue, which is fairly common in women. And if you have that, you usually will have that same experience multiple times. So had I not been in the position personally or chosen to pay for that additional testing out of pocket, like 25% of the women who opt out when insurance refuses to cover additional testing, it could have led to a more advanced stage by the time my next covered mammogram rolled around the following year. So as demonstrated here on this slide, you'll see as breast cancer stages advance, 5-year survival rates can decline rapidly, and cost of first-year treatments can increase exponentially. So again, timing is of the essence. So our first speaker today, I'll be kicking off our panel discussion, is Mrs. Barbara Grassley. Born Barbara Speecher on October 21st, 1932 at her grandparents' home in Sumner, Iowa. Happy belated birthday, by the way, Mrs. Grassley.
Thank you.
Barbara started school in Fredericksburg, Iowa, and then attended one-room rural schools in Chickasaw County. She graduated from New Hampton High School in 1950 and worked as a secretary at Rath Packing Company in Waterloo, Iowa. Barbara is married to this guy that you guys might know, Chuck Grassley. And she was married to him on August 22nd, 1954 at the Little Brown Church near Nashua, Iowa. They are the parents of Lee, Wendy, Robin, Michelle, and Jay. They have 9 grandchildren and 9 great-grandchildren. Barbara started to earn her degree at the University of Northern Iowa in the fall of 1954. She took time off to raise their children and to support the senators' campaigns for the Iowa legislature, U.S. Congress, and the U.S. Senate. Barbara returned to UNI in 1981 and earned her degree in accounting in 1983. She's a member of Prairie Lakes Church in Cedar Falls, Iowa, and she participates in the Congressional Club, Republican Women Federal Forum, DAR, and Senate spouse activities. Barbara is a 36-year breast cancer survivor, and she's here to share her survivor story with us. Thank you for being here. Welcome, Mrs. Grassley.
Oh, thank you so much. I think this is such an important forum to have because so many people don't seek the treatment that they need as quickly as they should. And so it's wonderful that you are alerting people that what is available to them now. Tell me your story. Well, she said, Penny is telling me I should tell my story. You know, this is the thing. You don't know that everyone isn't just like you because we are all different. And so I did notice that my breast was swelling when it should not have been. And so finally, I did go and have a mammogram. And of course, they showed me the results. And I was, shall we say, amazed that something that big could grow so quickly, although it really wasn't quickly. And then what the ramifications were and what they could be. So I'm here now after being a breast cancer survivor for 38 years, and it works.
Great. Does anyone want to ask any questions of Mrs. Grassley at this moment? We'll also be taking questions at the end, but you can raise your hand physically or in the chat, use your little emoji. Or I'm not sure, Chelsea, can you see the chat as well to see if there's any questions coming in via the chat?
I'm going to join Barbara. No.
I'm not sure who was speaking.
Senator Sweeney, do you have a question?
Yes, I do. Hi, Barbara. It's Annette Sweeney. I used to be your senator.
Of course, that's all right.
Yeah, it's nice to see you. Hey, could you tell us some of the follow-ups? They found out that you had breast cancer. And today, what do you do for follow-ups to keep that nasty cancer at bay?
Well, I am just always more aware. And I think so often we tend to ignore what our body is trying to tell us. And I don't know if that was my situation or not, but I'm glad that I found out what happened or what would happen, and that I did have my surgery all those years ago. And I know I was walking down the hall with a doctor. I wasn't on one of these gurneys where they were wheeling it. I walked down. And I knew that I also had a small lump in the other breast. And I said to him, Doc, if that one's malignant, I want you to take both breasts. I said, you're a nice guy. I just don't want to come back here again. And so he was very accommodating. They did take out the small lump, which was benign, by the way. And here I am.
Well, great. I'm glad that you are here in leading this discussion and giving us your personal reactions and how you persevere. So I appreciate you. Thank you.
Well, this is what we do.
That's right.
Keep on keeping on.
Right. Thank you, Mrs. Grassley. As a newly diagnosed breast cancer patient, I'm inspired by seeing you here today and having you tell your stories. So thank you very much. Appreciate it. And we will take more questions at the end if anybody has any.
Yeah, Dana, I'm just going to jump in real quick because I know
Yeah.
that we are honored also as well to have Congresswoman Mariannette Miller-Meeks with us. And I know she can't be with us for the entire duration, but I just wanted to offer Representative, if you wanted to say anything, you're welcome. I know you're amongst friends here. And so I would like to give you the floor if you would like to have the opportunity to say anything.
Well, thank you so much. I really appreciate it. Mrs. Grassley, pleasure to see you, and you really are an inspiration to all of us. So it's great to see you. It's great to be with all of you. We just had a bipartisan press conference last week on Breast Cancer Awareness Month, and my comments were directed towards prevention, treatment, and recovery. And so often we forget about the recovery part. So I was glad that Mrs. Grassley was asked, what does she do now? What does she do to make sure that she continually is looking for other signs of cancer, that they're able to detect those early? And we know that prevention, an ounce of prevention is worth a pound of cure. So certainly early detection, be that through self breast exams, be that through mammograms, and now, as we know, there are genetic markers that we can test that can let us know if women are at risk, but also there are blood tests that will detect a variety of cancers. So screening is going to become much, much easier in the future. We know that treatment, when I was a nurse, we did a complete mastectomy. And this was after just a needle biopsy. I was not fond of that as a nurse and thought it was not the right treatment. And we know treatment has changed drastically since that time. With earlier detection, but also treatment, and then treatment according to markers, according to lymph nodes, whether there's chemotherapy, radiation, and then personalized treatment in accordance with cancer markers. So treatment has changed, and then there's recovery, whether women undergo breast reconstruction, whether they undergo augmentation, or whether they have prosthetic devices. And we just passed a bill for customized prosthetic devices to be covered by Medicare, so that women would have the full range of options, so they feel like they're their normal self and just as attractive and wonderful a woman as they were before undergoing lumpectomy or mastectomy or radiation therapy. So be it the legislation we have done, like the Mammo Act and the Service Act for young women in the military that are in toxic exposures, that they can get mammograms and 3D mammography at an earlier age without waiting till they're 40 and the recommended time period to have mammograms. If there are women who have a genetic predisposition, that they get mammograms at an earlier time, blood tests for detection of cancer, all of those things we're putting across, as well as access to care, access to providers, telehealth, so people can access providers despite where they live. All of these things are things that we're working on here in Congress to make sure women have the full complement from prevention to recovery, so that this is not as scary a thing as it used to be, and that we can all return to our wonderful, productive selves. So thank you for that.
Right. Thank you, Representative Miller-Meeks. Appreciate that. Okay, then our next speaker, I'd like to introduce Rachel Preisser, MD. She's a diagnostic radiologist specializing in breast imaging. And she's currently serving as Director of Breast Imaging Services for Mercy One in Northeast Iowa, excuse me. In this role, she serves as co-director of their NABPC accredited breast center and oversees breast imaging services of the region's community and critical access hospitals. Prior to her current role, she was in private practice in the Des Moines metro area. Her education includes graduating from the University of Iowa Medical School. She completed her residency for radiology and a fellowship at Allegheny Health Network. And she's also completed her breast imaging fellowship at UC Health Diane O'Connor Thompson Breast Center at the University of Colorado. Her clinical interests include high-risk screening programs, breast cancer-associated genetic mutations, image quality control, and advanced breast imaging technologies. She serves on the board of directors for the Iowa Medical Society and on committees for the Society of Breast Imaging. Dr. Preisser is here to share her passion, experience, and expertise working with and for breast cancer patients. Welcome, Dr. Preisser.
Thank you for having me, and thank you for that introduction. I also want to thank Representative Miller-Meeks for doing a lot of my talking points for me. I was wondering how I was going to get this into 10 minutes. So you hit a bunch for me. That's great. And I really want to thank everyone who's been sharing their stories. As a breast cancer doctor, it's my privilege to hear my patients' stories. We're coming off of Breast Cancer Awareness Month. We're all aware that it's super common, but hearing the individual stories and how it impacts not just the patients, but their families, that's a real privilege. And it also kind of makes it hit home how important it is to find it early. Because when we find it early and we treat it early, it's not just that patient that we're affecting their community and everyone else whose lives they touch. And so that's really what I like to focus on is prevention. If we can, we don't have a cure for breast cancer yet. And some of those biggest risk factors, being a woman and getting older every year, we can't do anything about that. We can't do anything about family history, even though, 75% of ladies who are diagnosed with breast cancer have no family history of breast cancer. So it really is something that can happen to anyone. And so until we have that, we have to use the tools that we have. And the best tool that we have is screening mammography at this point. It's the only study that we have that has been shown to reduce breast cancer death. And it has done so by about 40%, a little over 40% since the late 1980s, which is remarkable. The problem is, though, that screening mammography only works if you're able to act on it and if you are someone who's coming in and getting that screening mammogram every single year. And so for so many ladies, they come in and they get their screening mammogram because insurance is covering it. It's no cost to them. It's a pretty quick exam. It's only 2 pictures each breast, and it's in and out 15 minutes. But what a lot of folks don't understand is that a screening mammogram can never be abnormal. Okay, you can only have a normal exam or an incomplete exam. And if you have an incomplete exam, in order for us to know what's going on and to be able to give you a good answer, we have to do more. So that's where the diagnostic imaging comes in, whether it's extra specialized pictures in a mammogram, whether it's an ultrasound or an MRI or a biopsy. We have to take that next step. And unfortunately, in our state, for most folks, that next step isn't covered by insurance. And as we saw earlier in this presentation, that is a limitation. That's a barrier to care. And so even if I, as the radiologist, identify a breast cancer when it's teeny tiny, it's too small to feel, if that patient has to make a decision between paying for electricity or paying for dinner for their kids versus coming in and paying for that mammogram out of pocket, maybe they put it off. And in the meantime, those cancerous cells are growing. And so the opportunity that we had to get in there early, when we had more treatment options available, when we could be more conservative in our surgical approach, and have, a better recovery on the other side, we lose that opportunity that we would have gained from the screening mammogram. And so it really is a barrier. I know that in my many roles and my many hats that I wear, from an administrative perspective, access to care is always something that rises to the top. And access can look like a lot of different things. Is this service actually available to my patient? And sometimes that's about, do I have the right doctors? Do I have the right machinery? And certainly those are issues for us in our state, especially in some of our rural communities. But then there's also, okay, that exists, but my patients have barriers to get to it. And that's something that I deal with every single day, multiple times a day with multiple patients. And it's not necessarily who you would think. I mean, most of the folks who are having trouble getting to that diagnostic imaging are folks who have health insurance, but maybe they only are offered a high deductible plan through their employer. And they haven't met that deductible and they have other expenses. That's what I hear most. And we don't really have programs that address that gap for our patients. And so they have to make those tough decisions. So that's one big focus. And I know we have a bill that we're trying to get through that addresses that. And other states have done the same. And in those states, my coworkers and my colleagues who work in those states, they have more time in their day to do other things like talk about high risk, talk about prevention, and get other family members to come in and get genetic testing. They can be more impactful when they're not spending a good chunk of their day talking about insurance and the lack thereof and the lack of access. So that's something that would be a huge impact for our patients here in Iowa. The other thing that this kind of rolls into is that here in Iowa, we actually have many pockets of our population that has higher than average risk for breast cancer. One of the areas where I used to work, we were looking at 40% of our population being at high risk for breast cancer, which is outstanding. I mean, it's 3 times what it should be. And so for those folks, we need to start screening them earlier. We need to offer them supplemental screening, and we also need to offer them access to other things like tamoxifen and other strategies to help them reduce that risk and also to find those breast cancers that they're at higher risk for. Oftentimes that comes as a breast MRI. And those breast MRIs are very expensive exams. They have to happen every single year in order for us to effectively find what we're looking for. And even though they're expensive individually, we know from studies that when we use them in our high-risk population, we actually save money as a healthcare system, because instead of dealing with a later stage cancer that we would only diagnose once it gets to the lymph nodes, we're finding it when it's early, when it's only a few millimeters. And so that earlier slide, it's actually one that I use often myself, where we look at that cost differential and what does it cost to treat an early stage breast cancer, a stage 0, stage 1, versus what does it cost to treat a stage 3 or stage 4? Sometimes the difference is $100,000. And that's not just a cost that is passed on to the patient. That's a cost that the entire healthcare system absorbs and gets passed on to everyone as higher premiums. So it's not just a woman's issue, it's a community issue. And if we can focus our efforts on a lower cost preventative exam, even if that preventative exam, like an MRI, seems like might be a little bit more expensive than a mammo, we really will reap the benefits, both financially, but also saving lives, having higher quality lives for these women who are at high risk of breast cancer.
Great. Thank you, Dr. Preisser. I did see there was a question here in the chat about how the MRI fit into the diagnostics, which I believe you spoke to that already. There's one other question here that says, are there things we can do proactively to prevent breast cancer besides mammograms, lifestyle, nutrition, et cetera?
Absolutely. So, mammograms, we're just looking to find breast cancer once it starts, and we're trying to find it when it's tiny. We want to find it before you can feel it. Certainly, anything you can do to lead a healthy lifestyle. So maintaining a healthy weight, not smoking, limiting alcohol intake, all of those things that have good health implications for cardiovascular health, all of those things, that helps your breast cancer risk too. But breast cancer risk is very complex. There are a lot of things that go into it. And sometimes you can be at high risk of breast cancer and not even know. I often see young women who have dense breast tissue, and maybe they were a little bit older, late 20s, early 30s when they had their first kid. Those two things together can sometimes be enough to put you into that high risk category. So I really encourage all women to have their risk assessed by their healthcare provider by age 25. We often start talking about breast MRIs as early surveillance starting at age 25 to 30. So we need to know by age 25 if you're high risk in order for you to benefit from that study. And then you can also kind of take a look at your lifestyle. Is there anything I can improve? Could I do a little bit better on my diet? Could I stop smoking? Could I, if I'm really high risk, should I go see a breast specialist and talk about things like taking tamoxifen to reduce my cancer risk? If I'm really, really high risk or I have a genetic mutation, do I want to consider doing a surgical risk reduction with a mastectomy prophylactically? There are a lot of different options on the table when you are high risk, but if you don't know that you're high risk, then we can't offer those to you.
Great. Thank you very much. I've been through breast cancer and I learned a lot right there. So thank you so much.
Welcome.
Great. So we will move on here to our next part of the panel. And We're going to hear now from Susan B. Komen, Iowa team members Dana Carter and Alimian. Did I pronounce that correct? I was hoping. Alimian Allen. Together, they will share details of the legislative policy solutions that are being worked on right here in Iowa. I'll pass it over to you guys.
Hi, good afternoon, everyone. Thanks so much for joining. I'll be discussing 2 legislative solutions for eliminating barriers in access to care. The first solution is step therapy, also known as fail first. It requires a patient to try a therapy and have it fail. The insurance companies tell the patient what drug they must try on and fail before receiving the medication that originally was recommended by their physician. General step therapy is already law in Iowa. This would be an additional prohibition for advanced metastatic cancers, all cancers, not just breast cancer. This is for the patients who cannot wait to be on the correct medication. Time is not on the side of these patients. The patients who want to hear, you are stable on this medication, or you have no signs of progression. This is what step therapy would help with. They need to be on the medication that has been prescribed by their doctor, not on a medication that could potentially have serious adverse side effects for the 30 days that they are on it. Susan G. Komen has passed this in 11 other states, and there has been no fiscal report impacted on those 11 other states. The policy solution is to support SSB 1009 and HF 57 to increase access to medically prescribed treatments by eliminating harmful step therapy protocols for those living with all advanced cancers. And then going on to the next policy solution is no-cost diagnostic imaging. Approximately 12 to 16% of screening mammograms require that follow-up imaging for diagnosis. These would be MRIs, ultrasounds, and mammograms, and they can be quite costly for out-of-pocket costs, especially to patients who have been previously diagnosed with breast cancer, as they require more diagnostic testing than just traditional screenings and at a more consistent basis, perhaps 6 months rather than every other year. Some patients cannot afford the diagnostic testing and can forego or delay, which can lead to cancers being spread potentially to other parts of the body, making it much more deadlier and much more costlier to treat. HF 71 would eliminate these out-of-pocket costs for medically necessary diagnostic imaging by alleviating these costly barriers. There is a massive difference in costs. Some can range in the 200s, some can be over 1,000 for these diagnostic screenings. And that was from a Susan G. Komen study back in 2019. So in today's dollars, you can only imagine what that cost differential is. Susan G. Komen has passed this in 20 other states, and they have been primarily Republican-dominated states where the fiscal costs were estimated to be 3 to a max of 8 cents per insured person per month, making it a lot less than a cup of coffee for the entire year. In the state of Minnesota, the Department of Commerce stated it is not a mandate because it is not a defrayal of costs. And this bill would ultimately save insurance companies money by making the diagnostic testing that is seen or suspected, when it is seen or suspected, making sure that diagnostic imaging happens so they can treat it at an earlier stage and be much less costlier to treat. This policy solution of why this bill is needed is to increase access to medically necessary diagnostic and supplemental breast imaging by eliminating burdensome patient cost sharing. Thank you.
Great. Thank you, Dana, very much. I think there's one more question that popped up here that I probably would be addressed to you, Dr. Preisser. The question was, would the indicator for further studies be dense breasts or an incomplete study?
The answer is it could be either one. So let's start with dense breast tissue. About half the population, the screening population, has dense breast tissue, and that's just normal for them. And so what breast density is, it's not something you can feel. It's something that your radiologist assesses on your mammogram. And so there are different types of breast tissue. Some breast tissue shows up white on a mammogram. That's the dense tissue. And some shows up dark on the mammogram. The problem is that cancers also show up white on a mammogram. So if you have dense breast tissue, looking for cancer on a mammogram is like looking for a snowman in a blizzard. It can be nearly impossible. And so for those folks who have dense breast tissue, we want to look at supplemental screening. The best supplemental screening test that we have is breast MRI. It's the most sensitive. We find an additional 14 to 16 cancers beyond a mammogram for every 1,000 women screened. If you compare that to ultrasound, for ultrasound, we're only finding 2 or 3 per every 1,000 women screened. And the cost can, if you use an abbreviated, can be fairly equivalent. Problem is, insurance companies don't cover abbreviated breast MRI almost universally in the state of Iowa. So that is an out-of-pocket cost. I just had a patient a few weeks ago who had extremely dense breast tissue, and we diagnosed her cancer by finding it in her armpit because we could not see it even once we knew where it was. This was a huge cancer. It was like 3 centimeters in size, stage 2 at least. And we couldn't see it on her mammogram even after we later got the staging breast MRI and found it. We diagnosed her cancer because of a lymph node, and that's not what we want. This was a high-risk patient. She was actually even a healthcare worker who knew that she was high risk and knew that she should be having breast MRIs, but she couldn't afford it. And so she was skipping it. So she had never had a breast MRI. If we had had a breast MRI and caught that cancer when it was a few millimeters in size before we had ever seen it on her mammogram, it would have been a whole different ball game. Instead of being metastatic at time of diagnosis, she would have been stage 1. And, so breast density in and of itself is an indication for additional supplemental screening because the sensitivity of your mammogram goes down. And then could we repeat that question for the other part, the diagnostic part?
Yeah,
they were just
saying, oh, go ahead.
No. And so the other part of diagnostic imaging, I guess there are a couple different ways you can get there. A very common way to get to diagnostic imaging is just you have your screening mammogram and you are one of those, for the purposes of ease, 1 in 10 women who get called back for additional imaging. Screening mammography is a pretty simple exam. We're only looking at 2 pictures. And we get a lot of information, but not everything. There are often normal findings on a mammogram that can catch our eye or look abnormal just by getting into position a little bit different from year to year. Every single mammogram is different. It's like a fingerprint. It's unique to the person it comes from. And so there's this huge range of normal. The other challenge in breast imaging is that there's a lot of overlap between what normal looks like and what cancer looks like. So not only do we have a huge range of normal, we have a huge range of abnormal. And so it is the job of the radiologist to determine how to put those into the right categories. And so sometimes we have to call you back. And I think of screening mammograms as kind of like a colander or a sieve. You want to make sure the holes are the right size so that you're definitely catching all the cancers. You're not letting any cancers get through. But in order to have the hole small enough to not let any cancers get through, you have to have some normal too. And so of the 1 in every 10 people that get called back from a screening mammogram, only about 2 or 3 of those people are going to end up getting recommended for a biopsy. And of those biopsies, only about 2 or 3 of those people are going to end up having out of a larger pool are going to end up getting a cancer diagnosis. So there's going to be a lot of, some people call them false alarms. So we just call them we don't call them a false alarm. We just say, okay, good. We saw that and we got you back into normal. That's one way to get into the diagnostics. The other way to get into diagnostic realm is if you have a problem. And so if you notice something different with your breast, if you notice that's getting bigger, if you notice a lump, skin changes, pain, anything like that. Oftentimes these symptoms are nothing to worry about, but you never want to just put it off. You always want to have them come in and be evaluated and figure out exactly what's causing them. And if it's nothing to worry about, wonderful, but you don't want to ignore those warning signs. So there are 2 ways. You can either get called back because your radiologist sees something, or you can get referred because either you or your referring physician have a concern.
Great. Thank you, Dr. Preisser. I think we had some summaries here at the end that there were a couple people we're going to speak to.
I can do my little bit first. I think I already kind of talked to this, especially the imaging part. You know, this bill would significantly impact multiple patients that I see every single day. And it would make an impact in the larger community because we'd be catching these cancers earlier. These are folks who are, you know, in our community, their moms, their neighbors, their friends. And if we could help them have an easier breast cancer journey and make sure that they're in that, you know, early stage of diagnosis where their 5-year survival rate is 99% instead of 25%, we're going to be doing good for our entire community and our entire state. This is not necessarily my area of expertise. I'm not a chemotherapy doctor, but I did want to speak just on behalf of my colleagues who do work in that sphere to the metastatic step therapy. And, you know, these days, metastatic breast cancer doesn't have to be a death sentence. It can be more of a chronic illness, something that you live with for many, many years. And we want to make those years for those patients who have had a long breast cancer journey as productive and as fulfilled as we can. And part of that journey is to make sure that they have access to the medications that are working for them. This is a population of fighters. Typically, when you're metastatic, you didn't just end up metastatic. You probably had a breast cancer diagnosis first, and then it came back. We see that a lot. And so these are women who've been through a lot. And if we can help them have a longer, more productive, and easier course at the end, that's something that would be really impactful.
Great. Thank you, Dr. Preisser.
May I say something?
Yes, please.
Well, it's my understanding that this is also being shared with the Iowa legislature. And so I want to say to the legislators, I said, I don't need to tell you how the legislative process works. I will tell you I'm a strong proponent of breast cancer awareness, screening, and early detection. I encourage you to review proposed bills that would strengthen access for Iowa families. And thank you for letting me share my story with you today. As Chuck always says, keep in touch.
Great. Thank you. Thank you, everyone, for joining today. Thank you to everyone on the panel. Thank you to the attendees, the people that'll be listening to the recording at a later time. I don't see any additional questions in the chat, but there's an opportunity here for a little Q&A. If anybody else has any lingering questions, feel free to raise a hand and we can address those now. I'll give that just a second.
While we're waiting for you all to formulate any last minute questions that you have, I would again just like to thank you on behalf of our team here at Advocacy Strategies for joining, but also just a friendly reminder, both Dana with the Komen Foundation and Dr. Preisser talked about the metastatic step therapy. And I know that Representative Lundgren is on the call, and she was a champion of the step therapy legislation that we have in Iowa right now. And as you all know, and for those of you that were in the legislature, I know we passed that unanimously. And so just, for those of you that were involved in that conversation before, just understanding and knowing that this just takes it a step further for those that have metastatic cancers, and just specifically making sure that they have access to treatment for any of the issues and challenges that they have as they're going through that metastatic cancer diagnosis. I was pretty amazed when I saw how the numbers are that people are living longer today with metastatic cancers than ever before. And most of that's because of the treatments that we now have available, and just getting them, whatever, again, putting the doctor back in control of deciding what that cancer patient needs, because medicine is so much more personalized today than it ever has been before. And we know through genetic testing and all those sorts of things. I know Representative Miller-Meeks talked about that too, where we just know so much more today. That's allowed us to get ahead of the curve, especially when deciding which treatments folks need. So I just throw that out there, as I know it's been a topic of discussion before in the legislature, and one that you embraced wholeheartedly. And so we just ask that this just kind of takes it to the next space, particularly in the cancer and those that are literally facing a death sentence otherwise. So thank you.
Great. Thanks, everyone. That concludes our panel for today. I just want to personally say that I look forward to hearing the outcomes of all this hard work that's obviously being done on the subject matter. And I know that the women on this panel, the terrific women on this panel, look forward to working with you all during the next legislative session in January. So thanks again, everyone.